Please settle down, and we're going to go live to Leipzig in a few minutes. And I want to invite all my co-panelists, Dr. Ehrin Cawich, John Rundback, Mehdi Shishehbor is here, Ehrin Armstrong. How are you doing? Good? Okay, thank you. Dr. Khusrow, Niazi, John, good morning. Thank you. Welcome. Munier is here, and Dr. Bianchi.
Thank you very much for coming. I really appreciate it. Thank you so much.
We're ready. Give me 15 seconds here. Call Ehrin. So let's go live now, Rob. Good morning, Andrej.
Yes, good morning, hello.
Thank you for joining us from Leipzig. This is Subhash Banerjee from Denver at CVI 2017, and I have an esteemed panel here of experts that you are well familiar with. Dr. Ehrin Cawich from Arkansas Heart, John Rundback from Holy Medical Center in New Jersey, Mehdi Shishehbor, my colleague and co-director, Case Western Reserve, Ehrin Armstrong, University of Colorado and VA in Colorado, Dr. Khusrow Niazi, I think he's on his way here, from Emory University, Dr. Munier Niazi from University of Toledo, and Dr. Christian Bianchi from Loma Linda. So please introduce your team and let's go ahead.
Yeah, thank you very much, first of all, to invite us to participate. It's really a big honor for us and a pleasure. With me is Sven Bräumlich. He is one of our seniors here in the lab for many, many years. And well, you see, we started already a little bit on our first case. Maybe you allowed us to do whatever we found interesting, and therefore we actually choose here some relatively, or let's say very complex cases with which we want to show us some of our techniques, which I think are very helpful and really difficult lesions. So we have here one SFA which is extremely calcified, and then comes a case which is really complex. We'll show you later, and if we have time, another below the artery. But maybe first of all, Sven, maybe you can introduce the first case.
Andrej, we expect nothing else from you.
And good morning also from my side.
Sorry?
Go ahead.
Thank you. Sorry.
Yeah, I think it turned out that already our first case is very complex. Can we see the first patient slide? It's a 68-year-old gentleman with claudication of the left calf. His ABI on the left is 0.64. He has very calcified SFA occlusion and also disease on the right side with previous surgery as well as PDA of the right SFA. Next slide. These are the risk factors: arterial hypertension, nicotine abuse, and diabetes mellitus since many years. Next slide. This is the angiography here. The left SFA, you can see in the middle portion of the SFA actually an occlusion. Very calcified artery. This is better visible than in the native X-ray. Short occlusion here, but a huge collateral coming from the proximal part of the SFA, so that a previous recanalization attempt was not successful. Next slide, please. So that's why our strategy here in this case is come from a crossover approach from the right groin, and we already are prepared to do a retrograde puncture here from the high anterior tibial artery to cross these very calcified occlusion in a retrograde fashion. And our strategy here in these cases is really to open up the artery appropriately, crack the artery with high pressure non-compliant balloons, and in case of rupture, then we have, of course, to pave the artery and to pave it with a wire band and stabilize and reinforce the wire band with a Supera stent. And maybe Andrej now can present the steps we already did here in this case.
Yeah, thank you very much, Sven. So if you can switch to the angio. Okay. Here, so can you see the angio?
Yes, we can, Andrej.
Yeah, perfect. So this is once again here the SFA total occlusion mid portion. At the end it's not too long, but as you have seen, it is really extremely calcified. And yeah, what do you think? I mean,
while you prepare your steps,
filled with concrete.
I'm going to ask my panelists to weigh in, and let's start from my right and keep going in your preferred approach and brief in few minutes.
So I really want to see the popliteal before.
We want to see the popliteal artery one more time. Mehdi, your approach to this?
Here's the popliteal artery, just a moment. You can see there's also maybe an occlusion short one or stenosis behind these collaterals. So we did another angulation, and you can see it's a complex stenosis.
So,
sorry.
Based on that, really, I'll go distally because of that large branch. The wire will keep going into the least resistance.
That's
I'll go
correct.
distally. Yes.
Any other comments? John, you have any comments?
You know, obviously, you kind of start with your normal crossover and, you know, see how it goes. But I suspect with this large marginal collateral and calcification, you're going to get subintimal, may or may not be re-enter, but probably won't re-enter. We'd very early go probably what we learned from the Japanese, more of the anterior approach to the P3 segment, you know, between the tibia and fibula as a rendezvous. So.
Andrej, I hope you heard that. I just want to tell you, can you tell us what's your approach now that once this procedure we have failed to cross antegrade, are you going to go anterior tibial right away, retrograde?
Well, we always try once again from antegrade, but as has been mentioned already, the problems will be that the wire will always go into that collateral, and that also occurred with our attempts. And we really had, we are actually not yet at that point that some kind of wire goes here into the occlusion. With this calcium, I think there's clearly no way to get the wire, let's say, intraluminally through that plug. It will always be around that plug, subintimal or in the media. And with the calcification also distal to the occlusion, I think, as also has been mentioned, there will be clearly very many difficulties to re-enter distal. So we very much anticipate that this is a technique, a case where we have to go through from both sides.
Excellent. Any other comments from the panel while Andrej prepares?
So, yeah, please. First problem we had to go was to go crossover because also the iliacs were very difficult and very calcified. So you can see here that we were able to push a little bit here the sheath. It's a 7 French Cook 55 centimeter sheath, which will be positioned the tip into the proximal SFA, but the push forces were not enough to get the tip further than here, the beginning of the external. So in these cases, what we found very helpful is this kind of anchoring technique. So we took a 6 by 40 millimeter balloon, which we opened up here in that diseased proximal SFA. By anchoring here the balloon and wire, we could pull our sheath down. I find this very, very helpful if it's difficult.
Excellent technique. And
then the problem, well, this is something which we nowadays do in all these severely calcified total occlusions. It will probably be quite painful for the patient if we balloon this here sufficiently with 5, with 6 millimeter balloons. So what we do here is we give some local anesthesia here to the plug down. This is a 9 centimeter 21 gauge needle, and we give 1% lidocaine. We check different angulations where our needle is. You don't have to go into the plug, but around the plug. You don't have to do it every centimeter, but maybe every 3 centimeters, and it will spread, as we've seen with other techniques like the limbo balloon, where you inject contrast dexamethasone into the adventitia, that it spreads around the plug and goes proximal and distal. So we did this here for several points. You see here that we test also in one angulation whether with the needle, you can feel that plug actually, the calcium. You see maybe how the plug moves when you move a little bit the needle, as you can see here. Then you know that you're quite close to the plug, and then you inject some lidocaine 1%. That is extremely helpful, and really it became some kind of standard here for us in these calcified total occlusions.
Excellent point. Any of the panelists do this in their own labs?
Yeah, next. Once again, the outflow. So we had to go retrograde, distal SFA puncture. The occlusion may go down a little bit too far, and therefore we thought, well, the posterior tibial artery is open, the peroneal artery is open, but what you can also see is that the antertibial artery is also, at least in the proximal part, open, and then it is occluded in the distal portion. So by this, it actually becomes a perfect access artery to go retrograde. So, and also for popliteal and SFA or total occlusions, we want to actually have our retrograde approach relatively close to the occlusion, and therefore the proximal antertibial artery is, I think, a very good artery to gain access, especially in this case, because it's occluded distal. You can see here distal on the posterior and peroneal artery reach the foot. Yeah, that's nearly where we are. You can see here we started already here to get a wire in from Antegrade, but actually, yeah, wire always went into the collateral, and we could not push down a diagnostic catheter, not even a balloon which tracks over an old 35-inch wire, as you can see here, went through the plaque, the severe plaque, to the origin of the collateral. So we pre-dilated a little bit here with a 6mm balloon. We exchanged to an 018 wire actually to try, here once again I tried to take the wire into the plaque, but you see again it always goes into the collateral. I couldn't torque the catheter to another area to go maybe subintimal to our left side. It always flopped into the collateral. And we exchanged to an 018 wire and tried a 018 balloon, which also did not go through the plaque to the collateral. Then we changed to an 014 wire. And this here is a coronary balloon, a 320 coronary balloon, which eventually helped us here to open up that first part to the origin of the collateral, to be able now to have a catheter in, which gives us more stability to somehow get access here into the occlusion. Well, it turned out to be a little more complex than we thought, starting already with these kind of problems is hard. Let's see. So we have here now a 5-French diagnostic catheter. It's a mammaria catheter where we actually cut off the tip a little bit to give it more stability to grab into the plaque. Once I twist it or torque it to our left side, I hope it will give me more stability, this cut-off tip, than a regular catheter with a smooth tip. But of course, to bring down the catheter, that is only possible once you pre-dilate it here down to that area where the collateral has its offtake. Any other ideas here to engage?
Well, I'm going to ask my colleagues here. Anyone prefer to try a CTO crossing device to that catheter to get it through? Anyone? Ehrin?
I tend to use primarily a support catheter wire strategy, and I think a concern here, even with a CTO crossing device, would be that you'd still redirect into the collateral. The one exception to that could be using a laser, perhaps with a step-by-step technique to soften that cap, so then you could then engage the wire better.
Yeah, the difficulty here remains the same. Even if you start that subintimal plane, re-entering is going to be extraordinarily challenging. So, we actually learned from Andrej and these guys that we kind of the half an hour rule. If we're not getting it quickly, we just go retrograde and create that subintimal rendezvous. So.
Makes sense. Ian, a question for you. In case if there was no popliteal disease, would you have taken a anterior tibial retrograde approach if you needed to, or you would stick the popliteal artery here if there was no disease in the popliteal artery?
I still think you can get good pushability and access from the proximal anterior tibial, so probably be my choice.
Mehdi, you were saying something?
Yeah, I just interested to see how come Andrej is not going retrograde or popliteal, given that he's having a little bit of a challenge because of that collateral. Why he hasn't gone to the popliteal or a retrograde approach to cross that segment in a retrograde way?
That was my question. So, Andrej, the question from the panel is, and from Mehdi, is that that you are persisting with an antegrade approach still.
Yeah, why not go directly and retrograde?
Correct.
Well, I think also from retrograde you will see the same problems probably as we see here from Antegrade. That plaque material is just too hard to really pass easily. I think you need very good support, many pre-dilations to get your catheters wires further in. Clearly, maybe from retrograde, the problem is less that the wire always will engage collaterals because collaterals go naturally downwards. That is sure, but here, for example, I have the impression that with small wire, small balloon, we are able now to pass a little further down. But at the end, definitely, I think I need a retrograde approach. Yeah, I mean, in this extremely calcified arteries, I think the risk of perforating at some point is high, and the risk, if you come from both sides, is diminished, or you can at least, if you perforate from one side, solve the problem from the other side. But still, we first try a little bit from antegrade, predilate as far as we can go down until we go retrograde. That also, I mean, is helpful for the retrograde passage when we have predilated a little bit the plaque already from antegrade.
So Khusrow and Christian, any other comments?
Can I ask a question? If he would have common femoral disease, his approach would have been the same?
Andrej, did you get the question?
Whether there is a... Sorry, I didn't get the question, maybe.
If the burden of disease in the common femoral would have been significant, would you approach the same?
Yeah, you mean hemodynamically significant? Probably not, no. I mean, I would probably first treat or let surgery be done on the common femoral artery before I treat this artery here. There is a little bit of a profunda stenosis. However, I'm not sure whether this is really significant and will help him at the end sufficiently. But clearly, if there would have been more, we would have done different. Well, that doesn't look too bad. However, now it's subintimal. And what I don't want to do is here, I don't want to dissect into the distal segment. So therefore, I think this is now maybe the time has come where we go retrograde.
Yeah.
Of course, I mean, we can try now a little bit more to balloon down to here. We can pull the wire back into the balloon to let the balloon tip open freely, so to say. I could maybe use a CTO wire.
Subhash, this is a great technique, gradually going up and using the balloon to dissect the plaque and modifying the plaque. And he's showing it beautifully, the way he's doing it.
But really, I think to minimize damage, because if you end up going retrograde in two planes, it's a problem. To minimize damage, I will go from retrograde from the beginning in a good segment, because if it doesn't work, it's not going to work.
I think those are all great points, and I just want to allow to tell folks on the podium that there is a 3-second delay on the audio, yes, so please take note.
So I couldn't hear every comment because of the sound, but I heard that you would very easily, very quickly go retrograde. That's also what we do, that we do not try a lot to go through from antegrade, because every... if you try for a long time, the risk that you dissect and destroy that segment gets higher and higher. So one attempt with another wire or CTO wire, I think, is allowed, and that was not expected that it is actually so easy.
So Andrej, you beautifully demonstrated it.
Retrograde or the antetibial. Well,
but you still have the stenosis in the popliteal.
Okay, let's continue like this. And let's go through here. I think this is a complex stenosis. Another angulation. Maybe like this here.
Andrej, what wire did you cross it with? Was that a 018?
Yeah, that was an 018. That was actually the simple V18, our old V18. which may cross through here. Maybe we need, as I said, a 14 wire. Yeah, the other option would have been maybe to use here real CTO wire. What I like very much is, for example, the Connect 250T to really poke through the last remaining membrane here if you're unable to re-enter. Of course, now we also lost quite a lot of talkability of the wire going here retrograde. So the wire is not doing what I want. And the risk that we dissect here is also not low. And then we have to go retrograde, but well, okay.
But well.
This team looks strange, maybe a collateral. Nevertheless, let's go through. And I am very calcified. Oops. Let me try to redirect the wire now to somewhere else. Let's pull it out and give another angulation. Can I give it to you here?
So while Andrej does this, I think this is a beautiful demonstration of wedging the balloon and opening the distal cap. Yeah. Any other comments from the panel, Ian and John?
Well, so now we're going to get interesting how you treat that thing. I was curious, Andrej, about your idea of aggressively dilating and then putting a Viabond and then paving the Supera. If you aggressively pre-dilate, why wouldn't you go straight to Supera if you don't have a rupture?
Yeah, well, this is of course a technique which we preserve for those cases where balloons do not fully open, where we anticipate a rupture with severe bleeding. Sometimes we do this in cases where balloons constantly rupture because of the plug. So it's not a technique which we regularly use in calcified lesions. If balloons nicely open, of course, then we just proceed with this Supera stent directly. But it is really a technique which we found to be extremely helpful in those cases where ballooning is not easy. Well, the technique for us started actually with first rupture, be aggressive, rupture the artery, and then if you can't see the bleeding, take a Viabond in and then reline this with Supera stents. And then it changed to a technique where we take first a Viabond in when the balloon does not fully open, when we anticipate that there's no way around an intentional rupturing of the artery. And after the Viabond is in, then we really aggressively balloon, and then we reline with Supera stents, if necessary, but in most of the cases it's necessary. Yeah, I really find it a really very helpful technique. Would you consider atherectomy devices in this severe calcium? Well, I mean, it could help to open the balloon, but it will be so cumbersome to use, and I think the risk of embolizing here is so extremely high that also this, I mean, the Viabond, first take a Viabond in, is sometimes gives you just a very much safer feeling of preventing embolization. For example, in CLI patients, if Viabond is in, you can do whatever you want, no risk of embolizing.
So I think that's a great question for the audience and for the panel. So any takers for atherectomy here or straight with Viabond?
I don't think atherectomy here will do much good. I think here you have to just pave it with a Viabond and then just crack it with a balloon, high pressure. Otherwise, you'll get poor expansion of your stent.
Same approach?
No, I really, because he already dilated, there's no point of doing atherectomy.
And how many of you will take the Viabond all the way down, or just make it at the most calcified area, or you want to take it down to the proximal popliteal artery segment? John, you would take it down, Ehrin? How low you will go with the Viabond here?
Well, with the Viabond, I mean, obviously you want to stay well above the knee. I'd just take the Viabond to the point of reconstitution. I would not Viabond across that mid-popliteal lesion. I would treat that another way. We had a paper we published showing once you get Viabonds across the knee joint, those patients, have high rates of amputation. They go down badly.
Ehrin, any other approaches you would suggest?
Yeah, I agree with not placing the Viabond down much farther than the distal SFA. The concern there, obviously, is the Viabond occludes. There's going to be lack of sufficient collateralization and greater likelihood of presenting with acute limb ischemia. So I think with regards to atherectomy, I think I would be concerned with the extent of the subintimal approach. More proximally, I think using some type of atherectomy within the popliteal lesion perhaps would be reasonable because it does appear to be pretty bulky exophytic calcification. And doing so might help minimize dissection and not having to leave a scaffold behind perhaps if you used a drug-coated balloon in that area.
Good points. Mehdi, Khusrow, and Christian. So, relining the Viabon with a Supera stent is not a highly prevalent technique. So, how many of you actually practice it, and when do you think that is a reasonable approach?
I mean, I think folks have used it in the setting of aneurysm, popliteal artery aneurysm, to give the Viabon the support across the knee, as John was mentioning, across the knee with Viabon, sometimes you can get kinking. I think in this situation is interesting. The balloon is actually, I am interested on Andrej's take on this. Since he's so subintimal, it seems like most of the calcium is on one side, and actually the balloon's dilated pretty nicely. Andrej, what are your thoughts about that? The balloon's dilated pretty nicely.
So to me, it's about...
Thank you for that. So
when it fails...
You can see here that this is a 5 by 40 millimeter balloon. This is with 20 atmospheres, and you can see here, I mean, if the balloon doesn't open like this, for superior stent implantation, we all learned that the balloon has to be nicely, fully open, and in extremely calcified lesions, you actually have to also oversize the balloon. So in fact, if I want to take here 6.5 superior, and I would actually predilate here with a 7 millimeter balloon, or with a 6 millimeter semi-compliant balloon, if I want to implant a 5.5 superior. But if I cannot open the balloon here, not even a 5, it tells me it will be extremely difficult to properly prepare here the artery. So either you really go now directly to a short, maybe 7 or 20 millimeter balloon to prepare for a 5.5 superior. And you can see here, as you said, maybe the plug will stay as it is, and the balloon will open to the other side, which is not diseased, and then you have the perforation. So this is something which, when I see this here, that makes me think of the crack and pave technique.
Andrej, would you take the approach where you hold off on stenting this lesion and just treat this aggressively with scoring balloons like chocolate, and then use a drug-coated balloon and see if this follow the arterial duplex? If it re-stenosis, you can always bring it back and then put the stent.
Yeah, I mean, there may be some cases where it works, but generally I think the recoil forces of such a plug are just too high. No, actually I will not rely on them. So this crack and pave technique, we have started with this actually 6 years ago. We haven't done many because it was, especially in the beginning, reserved it for extreme cases. Now we actually also do it more in extreme cases, but we treat now also more extreme cases since we have this technique. And we have also collected our data, and the patency rate looks good. I mean, in this extremely calcified lesions, most of them are also very, very long. We had a patency with this technique of around 80% after 1 year. So I think this is a really helpful technique, which really is one more armamentarium in difficult lesions.
I want to get back to the point of drug-coated balloons. I think given the extensive calcification, that might not be the primary approach.
The patient doesn't feel anything because of this local anesthesia. And you see now how the balloon plopped open, and we may have a perforation now. So this is 16 atmospheres. Let's prepare for a shot and see how it looks like.
Andrej, I have a question. Is the patient completely pain-free?
Absolutely pain-free with this local anesthesia around the plug here.
Excellent. So time for
Viabon. There's a little
Viabon.
bit of perforation. This is actually not really of big concern for me here now. Although at the end, we actually don't know what will what is the future of that? Will a pseudoaneurysm occur with this here? I think we still need some more aggressive ballooning here.
What size was that last balloon, Andrej?
Actually, maybe 640, semi-compliant. So it was with 16 atmospheres, probably 6.5. millimeter in diameter. Sorry, hier nochmal. Yeah.
Any reason you don't?
The question is, shall we implant here a 6.5 Supera or only a 5? So this balloon is now nicely open. Leave it open a little bit for 60 atmospheres. I think also very helpful and very important to check the balloon in different angulations. You may see some waste in another angulation. Here, for example, mid portion doesn't really make me happy. What do you think?
There's still a compression of the balloon.
Andrej, any reason you're not using a long balloon for long inflations like 8-10 minutes?
Yeah, I think with a short balloon, actually I'm planning now to change to a 20 millimeter long balloon. You can do more focal pressure ballooning. Long balloons may open proximal, distal, may look a little bit like a dog bone. And therefore, if we see a waist in a long balloon, we take short balloons in.
So Andrej, at what point, in regards to safety, if you're concerned about perforation, at what point do you put the Viabond first and then dilate inside the Viabond if you have concerns and you are not as experienced as, one is not as experienced as you are?
That is exactly was my question. So,
yeah, that's also a good question. At what point? Here, this case here, I have the impression that balloon opening is not so bad, actually, as expected, due to the severe calcium. Now it's ruptured. Nochmal ein 640 oder so ein 27? 27? 47 Pacific. So if the balloon doesn't open at all, and we have, then next step would be either atherectomy device for that focal area, or a real high pressure balloon like a Conquest where you can go up to 30, 40 atmospheres. And then I would first take a Viabond in and then rupture.
I just
What's really interesting.
The problem is maybe that
speak into the microphone.
In some cases where you, start to take a Viabond in, where you see your balloon's not opening, and then you take a Viabond in to have real high pressure, and it does not open then of course your options are very much limited. You cannot do atherectomy anymore. So in many cases we try to push out Viabond implantation as far as we can until we have some kind of rupture, and then we start Viabond before we have a real big rupture.
So what's really interesting is you're deciding in advance of the implant whether you're going to go with Viabond or Supera primarily. Because if you're going to go with Supera, then you're going to take big balloons very aggressively. If you're thinking Viabond, you're not going to dilate as aggressively until you place the graft. I mean, that's a pretty good balloon dilation alone.
So let me ask a question. How many of you will forego the Viabond at this stage and go directly with Supera? So raise your hands on the panel, and I think on the floor there are a lot of experts here. So you can come to the microphone. Tony, any advice? You'll...
I will put really one at that area and then do Viabond the rest of it, the other way around actually.
So, Andrej, the advice from the panel, whether you choose to accept, is maybe to also consider foregoing this Viabond approach and go straight with Supera.
Yeah, we're also currently discussing it here, maybe first straight Supera. But now we also discussed the diameter of the Supera, whether it's a 6.5 or 5.5. And actually we agreed that we rather take a 6.5 in. What do you think?
I'm going to ask the panel here. Christian, Ehrin?
Yeah, I think a 6.5 would be reasonable here. I mean, the majority of the time in these arteries I use a 5.5, but this is a pretty large reference vessel, and you've gotten great dilation with these 6 millimeter balloons, so I think a 6.5 would be reasonable.
You know, it might be interesting at this point, you're doing so well to go with a 7 millimeter DCB and, sort of dilate that, see how it looks with the 7 millimeter DCB, and if you even need the scaffold. I mean, this is actually looking pretty remarkable.
I think going back to the selection of devices, most of us are not saying it, but the reason of not thinking about the Viabond first is the collateralization and the mode of failure. When you have significant collaterals and you Viabond them and then the Viabond fails, you have a more likely to have an acute limb scenario as a failure mode of presentation. If this would have not had those collaterals, I think most of us would have been more comfortable doing a Pave and crack technique. Regarding DCB, I think the calcification may limit the penetration of the drug, and I'm not quite sure I would go with that.
I think Andrea's group has already published use of DES in long lesions. So how many on the panel will actually consider implanting a Zilver PTX or a DES stent here? Anyone? You can raise your hands or say your comments here. Ian, I want to invite you to this.
There is data on the Japanese post-market on highly calcified lesions and how they behave in this environment, and they seem to be positive data. So it is certainly a consideration.
Hey, Andrej, can I ask you a question? Given that you may not do that crack and pave technique, can you give us some information regarding your sizing of the Viobond relative to the Supera, given that Supera comes in half sizes and the Viobond doesn't? How do you size the two?
Yeah, good question. And easier for us in Europe because we still do not have the half sizes, unfortunately. So therefore, if we implant a 7 millimeter Vioband, we take the 6.5 outer diameter Supera in, which fits very nicely. Then it's really no problem to take it in. However, the Vioband really has to be also absolutely nicely open, and a 6 Vioband is a 5.5 Supera. Whether a 7 millimeter outer diameter Supera fits into a Vioband, I cannot say. You have to tell us. Yeah, I heard the concerns about collaterals. Clearly, this is also our concern, that the patient may get worse if reocclusion occurs. So therefore, also this is also something where we think twice, shall we take a Vioband in or not? And we actually reserve these collaterals, these Viobands also only for the very extremely areas, and usually the Supera or any other stent extends distal and proximal out of the Vioband. Yeah, what do you think? I mean, it is not so bad. Definitely, I would continue with treatment.
I mean, if another view shows a similar result, honestly, I would probably just do DCB and leave it alone and do surveillance, and you can always come back and put a scaffold another day. I'm surprised. I would have thought up front you would have needed the woven nitinol stent, but right now you've done remarkably well.
So Andrej, did you get that?
Yeah, our experience with drug-coated balloons and really these calcified lesions is not good. So we followed our patients, and we have the impression that really in very calcified lesions it is not so helpful. We have quite some restenosis, and we have the impression that from that some cases which we have then also retreated, that it's rather recoil or additionally at least partially recoil and not only hyperplasia. So no, clearly for us with this calcium, for us it's clear it's some kind of Supera stent, that would be crack and pave or Supera only. But here, in fact, we may not need the Vioband. We may just continue with the Supera stent. I think I do another angulation here to rule out any really severe residual stenosis.
I think without any significant perforation, I think Supera here would be nicely.
But why does he need anything?
Supera, yeah. There's some recoil. I mean, this is not perfect. Okay, Sunny, you have to implant the Supera. Do you feel safe taking the Supera now in, or do you want to have a Vioband and even more cracking?
I think the balloon opened up appropriately, also different obliques. So I think we don't have to balloon anymore. I think the Supera will open up appropriately. So I personally would go directly with the Supera. What do you think, Andrej?
I'm not sure. For me, it's a borderline case, quite a lot of recoil. Although the 7 millimeter balloon opened up nicely, we may have problems to take the Supera in. What do you think on the panel?
Well, I'm going to ask the panel here.
So I really will go with the Zilver PTX stent here and just pave it, and that's it. I'll not even use Supera here.
So Andrej,
I agree with you. I think that, given the mismatch in the size between the narrowed area and the more dilated area past that area that had the recoil, I think if you go in with a 6 or 6.5 Supera, you will have challenges, as you said, in the recoiled area. So I agree with you that, either you have to balloon that area again, or you have to go with a smaller size Supera, which will not have a good apposition distal to the recoiled area, or go with the Viabon as you suggested.
Yeah. That's also my opinion. Therefore, we leave this angulation here, and we do some more aggressive ballooning here in this angulation before we start to think of taking a stent in. Yeah, but again, of course,
really,
patients, maybe wounds may heal. You may leave it like this, but in the claudicant, I think restenosis is for sure, and therefore I think he needs a better treatment.
So I really worry about covering those branches with a covered stent because it's a very diseased artery, so it can block anytime.
Andre, how's your popliteal artery?
I think this is still an area where maybe collaterals are not so significant for patients. We know that if you stand down into the P1 segment, kill collaterals there, patients are usually worse later on. But this is an area actually where I think there are still more options for collaterals more distal. I think with the Viabon we also do not have to cover the important distal collateral which we see here. Balloon rupture 47 Pazifikus. And therefore, I'm not so afraid to cover these collaterals here, or that one collateral here. I would take here maybe a 700 Viabon in.
So how many on the panel would stick with Viabon in this case right now?
No Viabon.
Khusrow, are you still leaning towards DCB, or you've changed your mind towards now some other strategies?
No, in a de novo lesion, I would still go with the strategy of DCB and avoid stenting, and just do close surveillance of this lesion.
Ehrin, would you consider Tigris here?
Tigris would be another potential possibility as far as scaffold placement. I think it does have good conformability. My continued concern here is just this more proximal area here where there was significant recoil, and ensuring that whatever scaffold we place will have adequate expansion.
I think we are all leaning towards scaffolding this. Christian, do you agree with us?
Yeah, absolutely.
There is also a lot of disease in the proximal segment of the SFA, so I think we should start discussing what Andrej is going to do about it, and while he finishes up this case.
The truth is, we're at a good point now. The patency for a 7mm Viabon or for a 6.5 Supera are both very, very good. So we've sort of reached a good junction here.
And I think Andrej also raised a very good point that, the indication for a procedure is also important. If you have a CLI patient and you just want to heal the ulcer, it's maybe a different ballgame than when you have a claudicant. So when you want to leave the lab, you're thinking of 5-year patency, not that, I have flow, decent flow, and that it's going to be okay. So I think that's something to take into consideration, that you want to give this patient, the longest patency possible.
There are 4 microphones in the room, and I know there are a lot of experts who do this day in and day out. So if there are any comments and questions for Andrej or for the panel, I would invite you to use all the 4 microphones in the audience. So please do avail of yourself of the opportunity. But I think, like Mehdi said, there are many learning points of this case, right from getting the sheath in, deciding on a strategy based on the angiograms, having a contingency plan, and of course changing the plan as the procedure advances.
And clearly the most remarkable take-home point is that this is an endovascular lesion. I mean, here's a lesion that by their admission they could not cross in the past, and they brought back, but I would venture to say a lot of people here would say this would have been a bypass lesion, and but with these techniques and this sort of diligence and step-by-step approach, these can be treated percutaneously. So.
I also notice Andrej, and of course he's extremely experienced, takes angulated images for balloon expansion, which is also very, very important. Any other comments from the panel?
Okay. 27 Pazifikus.
Ian, you are a big expert in using ocelot crossing catheters. Do you see hope for it in this situation?
No, I think there's so much calcium there. I think your approach there of going subintimal from the start, just a wire and a catheter. I don't think trying to stay luminal here has any benefit. So much calcium.
Is there anyone in the panel who would use a crossing catheter in this case? Anyone?
You know, the ability to go retrograde has really largely eliminated the need to use crossing catheters. Yeah.
I think it's so important that how much time Andrej is spending to pre-dilate this lesion. I mean, you know, we really, I think to me that's the most important teaching point, to be honest, because we typically go in there with one long balloon, we inflate, we get out, we think we have a good, and it's just impressive the amount of effort he's putting to make sure that this thing is expanded before he commits to some kind of a scaffold.
On that same token, I would invite Khusrow to make a comment. I've seen him do such cases and leave the balloon up for many, many minutes. Khusrow, would you do the same thing here, or you adopt a separate strategy?
Yeah, at my age, I need to take a break, you know, so I do leave the balloons long, you know, Subhash. But I would still stay with the strategy. I just avoid trying to put metal in the first time and see, just closely follow them, because many times they will come back with focal stenosis, not the whole vessel. And then it becomes much more easier for me to treat that.
You know, I was thinking that before, Subhash. So clearly he's up and down with the balloon. So this is purely for vessel prep. This is not with the intent of, you know, getting scaffolding with the balloon, you know, attacking down dissections. You know, if this was a DCB or he's going to try to get away without a scaffold, then you see the long inflations. But you know.
How many of you would now agree that this vessel is looking more and more like a cover stent with a Viabahn? I think it makes me a little bit uncomfortable leaving this without a Viabahn right now, at least personally. And
so now we have rupture really and multiple areas of extravasation.
So Andrej, at least personally from my side, looks like a Viabahn may not be a bad option at this current stage. Many of my panelists do not agree and nodding their heads and shrugging their shoulders, but if they have other options, I invite them to say it right now.
You may think I tried really hard now to have a result where I need to take a vitamin. Well, this meeting here is actually not that terrible, I would say. I think it will seal. This is not the reason really for me for a Viabahn. But distal to that, the artery is relatively dilated now. And we have seen cases where we actually really have did all this preparation, which, as Mehdi said, is extremely important to take your time here, to take the Supera in. When you have this kind of dilation of the artery later on, take the Supera in, they come back and the Supera swims around a little bit. So it remains difficult to really find the right end of when are you prepared enough for the Supera and not. So here the addition of proximal balloon does not fully open, this little bleeding, and also that part of 5-6 centimeters of dilation of the artery, I think are altogether some good reasons to take now Viabahn in. And we're going to take it in now. We will be careful to at least save that collateral distal here. And after that, we will go in once again with a 720 millimeter balloon for post-dilation, and then take the Supera stent in. Okay?
Andrej, how's your popliteal lesion doing?
Yeah, I haven't checked yet, but clearly need to do this. I think that could be a case for maybe only ballooning, drug-coated balloon, muss man trotzdem dran halten, or, I mean, at the end, a short Supera stent, I think, is also not a mistake indeed. Okay, I think this here is a good idea. Between these two collaterals, what do you think? Okay.
Does the panel agree on the location?
We have a closer look to the distal one.
I go with that area actually.
I agree too.
Yeah.
Yeah, as I said, I mean, we do not do this very frequently, only for extreme cases, but collecting now also the follow-up data makes us really believe that it's really helpful, I think.
Subhash, many times we teach to go from normal to normal vessel. In a diseased vessel diffusely like this, there's really no normal to normal.
Yeah, and as I said, this technique, crack and pave, is usually a combination technique where we then either take a Supera stent a little further down, or a drug-coated balloon, or a drug-eluting stent, or whatever. So let's take the 7.
Which wire is he working on?
Balloon in.
18. Over.
And of course, if it looks good, I mean, then we have again the question: is the Supera still necessary?
Well, that's a great question.
We still see some segmental residual stenosis, and then we do take a Supera in.
Well, we will decide after you dilate this, Andrej.
The Viabahn may have enough. Sorry?
You're going to dilate this now, so we'll see after that.
Yeah.
My experience has been that when you focally force dilate inside the Viabahn, you actually get pretty good effacement. I mean, we're learning. I'm always learning from Andrej, but we have not done the Supera inside the Viabahn. It's ingenious, but having not done that, we found that we can open it up with a short balloon, for the most part.
Anyone on the panel, starting from Christian and Ehrin and Ian, would now still go with the Supera? Andrej has an excellent question for us. Yes, no?
I think, like you just said, we need to take a look at the picture result and figure it out. I'm not acquainted with any data on the combination therapy, but you can go against Andrej anyway.
Yeah, I would say that given that this is not in an area of enormous torsion, that it may be reasonable just to use a Viabahn here, depending on what the result looks like. On the other hand, if we had placed it further down, then I think that using a Supera inside would be reasonable to maintain the mechanical support.
I don't think, but I don't know if there's any risk now of recoil down the line inside the Viabahn. I wonder what Andrej's experience is. So is it sufficient that it looks good now, or still may there not be enough hoop strength in this stent that it will have recoil and narrowing later on?
Makes sense.
So we did a number of popliteal aneurysms, and they look really good. We followed them, hardly any occlusion, without Supera, without anything really.
Andrej, what is the size of this balloon you're using?
Yeah, 720, so I balloon it up now to 24 atmospheres, which, the balloon may have ruptured already at the plug without the Viabahn. And it still shows recoil here, the artery. Yeah, so what next? I mean, you could take, and we have done it, for example, a 5 and 8 millimeter 820 balloon. Haven't seen destruction of the Viabahn. You could take, of course, a high pressure Conquest 720, which will not open to 7.5.
That's great.
Yeah, so you see here some recoil. It's not completely ruptured, that artery here. But it may be enough to take now a 6 millimeter balloon ins Conquest 27 oder 28. And of course, you may also think that now it's open enough. And although this is not a stent with high radial force, may be enough to prevent severe recoil. These are some open questions which we also have, of course, still.
So the question is that how much radial force will Supera have in this heavily calcified lesion to prevent this recoil? So with just a show of hands on the panel, how many of you will just leave it the way it is and accept what Andrej's question? So we have 2 out of our 7 panelists, 3 now. Ehrin, you change your mind?
Well, I want to look a little closer at the mid segment of that Viabahn. There is some recoil, and if we convince ourselves that that recoil is not significant, either hemodynamically or with other imaging, then I would say we could stop. But I do want to make sure there's not significant recoil in the mid segment of that Viabahn.
Well, that regard is very simple. You can just sort of see if you feel a pulse. If the patient has a pulse back in their foot now, I mean, this looks pretty amazing. Obviously we have to be resource-minded as well to start opening additional stents without additional reimbursement, without clear benefit. I think is something I'd stay away from.
And Andrej, would it be worth considering not to pave the entire Viabahn with Supera, but use it in some select spots? Have you done that?
We also have done that, although in most of the cases the Supera was actually extending the length of the Viabahn. In most cases, proximal and distal. Yeah, again, I mean, 80 patients, actually, yeah, nearly 80 patients, not too much to be absolutely clear about this technique. And in this case, again, yeah, I don't know what the best option is now, whether to proceed directly with Supera. It is borderline recoil now here. We have seen clearly more after taking Viabahn in, and also cracking. But in this case, we may do this without an additional Supera. What I find now very helpful is actually a real high pressure balloon, like the Conquest here, which I have in here now. So this is a non-compliant, completely non-compliant balloon, which I now can open up here very safely, up to 30, 40 atmospheres.
And this is 7 millimeter?
For a while.
720.
It's 720, exactly.
Mehdi, you missed a good question. Are you happy with this result that Andrej is going to show, and not use a Supera inside the Viabahn? The second question to you is that, do you think if there is recoil of the Viabahn, will Supera actually prevent it, or you will only use some spot Superas? So these are the three questions we discussed while you were away.
I mean, I think that Andrej has done such a fantastic job of pre-dilating this lesion that the Viabahn looks great. If there is a feeling that there is still recoil, I do think that the Supera will open it. I believe it would, because he's now post-dilating it. But it looks pretty good, Andrej. What do you think?
Yeah, it does look actually pretty good. So now I have, as I said, 720 Conquest balloon up to 40 atmospheres for quite some time. I think there are not a lot of cases where we actually would do this without, the safety of having a Viabahn in.
I think more and more of us on the panel here are leaning towards doing what you are just doing without using a Supera inside it.
Can I ask about failure mode of the Viabahn, which is an edge, not in stent, and what is the recall that he would accept not to increase the radial force?
Andrej, did you hear the question? Christian?
Yes, and I do not really have a clear answer, but in many cases we see some kind of spiral dissection, residual stenosis due to spiral dissection up to maybe 30%. That would actually be my cutoff. And this clearly is not the case here, I would say. I can imagine we come along here with some more prolonged ballooning here with a 720 without a use of a Supera. And I heard, the problem are the edges of the Viabahn. Clearly we would, there's also some disease distal and proximal. These are, I think, good areas to take a drug-coated balloon in, and we planned actually to take here a Stellarex drug-coated balloon then in. But I have the impression now that the Viabahn is even better open now after this severe high-pressure ballooning. Maybe a little more. Actually, the balloon doesn't fit down now.
There's no downside.
For many of these cases, sometimes it is hard to...
Let me give you once again a shot and decide once again.
Sure, we'll wait for you.
And the rest will be just drug-coated balloon, proximal, distal, maybe Supera in the popliteal artery.
What I was saying is sometimes it is hard to predict how distal the dissection plane extends. Any of you would use imaging and not just rely on angiography because at the distal edge of the Viabahn. So any takers for imaging here, intravascular ultrasound? Or you would not incur the additional cost and you don't think there is great value to it? Munier, you?
No, we use IVAS, but we don't. If this is good, no need to put another $1,800 really.
Andrej's shown that you get multiple views, and our feeling is in with multiple projections, and generally you get a satisfactory sense of what's going on.
One other point of where this technique may be of advantages, as Mehdi also mentioned, and we all know, I mean, extensive predilation in discastile lesions and preparation is very important. And I mean, the more we predilate, especially in long and, let's say, muddy lesions, the higher the risk of embolization becomes. And therefore, I think this technique can really also maybe diminish the risk of embolizing in these kind of cases. So let's have a look here. Looks actually quite nice.
Andrej, what do you think just distal to the Supera, to the Viabahn implantation? Are you completely happy and satisfied with that area?
I think it's this, what I see here now, yeah, of course it's not perfect, but I'm happy that I didn't take the Viabahn across that area. And I think if we take a drug-coated balloon in, 640 maybe Stellarex, that could be enough. Here it looks a little bit more like a dissection here. Actually now I think of maybe take a drug-eluting stent across, maybe an Eluvia 740. Would maybe diminish our risk of edge restenosis of the Viabahn and also tackle that dissection here. Of course, also maybe a Eluvia. That could be an option.
While you plan this, I want to go back to my panel. How would we should deal with this distal dissection? Should we image and make sure this is not flow obstructive, so we do nothing? Any takers, Ian?
I think I would just treat it with a drug-coated balloon and see if it heals.
Yeah, I think personally I would use a drug-coated balloon at each edge here on these dissections that would have the advantage of hopefully preventing any neo-intimal hyperplasia that would lead to the Viabahn thrombosing over time.
John?
Yeah, definitely DCB. And, you know, I'm looking at this, and I don't know how about you guys, but as I'm in the cath lab, every time they're opening a package, I'm getting chest pains. Another stent. We'd go with DCB. You know, there's a pass-through in the United States. You do distal, you do proximal. I think it'll look great. And, you know, we've talked about this even in various, SABs, accepting a little bit of dissection with DCB because they remodel nicely. So.
How many of you will actually leave it? Mehdi, will you leave this?
No, actually I wouldn't, and I think that there are two issues here. There is one issue of the dissections that we deal with in the setting of DCB. Here, I think the concern is that you also have a Viabahn. And if the flow becomes hindered because of that dissection at the distal edge of that Viabahn, that's going to also compromise that Viabahn. So I think there are two reasons to be concerned about that. So I think that stent is not a bad option. I mean, you can start with a DCB and then put a Supera, or if, Andrej wants to use a DES, it's not unreasonable. It is also calcified, so I'd be interested to see if it's going to expand nicely. The Viabahn looks gorgeous.
I think it's the philosophy of why you're doing what you're doing. If you're doing it to prevent late failure for the Viabahn, some sort of biological therapy has to be used because you know that's a mode of failure. If you're worried about the dissection, that's a small dissection, no flow limiting, maybe something else you can use as well. If you want to approach both, I think certainly DCB will do the trick.
Khusrow, is this time for your long-term, long-duration balloon inflation action here, or you're going to just stent it?
I don't think so now. The long inflation is going to help because we have a Viabahn that's going from a disease segment and ending into a disease segment. And I think Mehdi's point is very concerning that, if those things shut down, then the Viabahn is jeopardized.
How many of you think that ballooning this could actually extend the dissection, so getting a stent out and taking care of this right now is probably the best course of action? Rob, are we coming on back? As we connect back, I just want to recap 4 critical points that I learned from this case, and I watched it, Andrej, many, many times. The first one is how to tackle and get a sheet over with a balloon placed in the proximal SFA. Second is careful multi-planar assessment of the lesion, preparing for a contingency plan, and this is typical for a hybrid case if this did not go well. And as you can see, long preparation of the lesion is also a great demonstration here. So please continue with your transmission here. Yeah,
I agree. The diligence to vessel prep here and the diligence to post-stent, optimization really was remarkable.
Absolutely.
Yeah.
Absolutely. Absolutely.
So please tell us what stent you are placing, and we are soon going to go over to the other room where Andrej is starting the second case. So.
Yes, as Andrej already mentioned, I implant now a truck-eluting stent, the Illuvia. First, to prevent later edge stenosis, and second, and more important now, to fix this dissection here distal to the wire one. This is a short stand here. More distally, I will go now with the truck-eluting balloon, truck-coated balloon, with the Stellarex, as well as the ballooning here of the popliteal artery again. I think this is probably sufficient. And yeah, Andrej is probably ready in the next room. And maybe we can switch to the other room while I finish this case and later on present you the final result.
Are they going to address the popliteal? Are they going to address the popliteal?
Yes. I think they have
the popliteal, I will balloon now with a truck-coated balloon. Ready?
This is a beautiful demonstration. We applaud your great action, and we are ready here to move to the next room whenever you are ready to transmit. Thank you very much.
Thank you, Ismail. That was a great case.
Great case. So Mehdi, you suggested that you would have probably gone directly retrograde, is that right? Can you tell us a little bit about your approach to retrograde access here? Would you have still picked up the proximal and AT or gone popliteal?
Yeah, I mean, I think I would have gone popliteal, but I learned from Andrej. Every time I watch him, I learn from him. I think that being patient and, he very nicely showed that little by little he was able to get around that collateral and cross the lesion in an antegrade fashion. But if I had to go retrograde in this situation, I would have gone popliteal and tried to see if I could cross it. It would have been challenging in retrograde too, because you need a lot of force, you need a lot of backup. So we probably would have had to put a sheet, and that would have made the case, a little bit more complicated. So it was nice to see Andrej cross it in this way.
They used a drug-coated stent at the distal edge of it. How many of you would have gone with a Supera here?
Yeah, I mean, I think, if you're asking me, I would have probably done DCB and Supera, because I think that's now getting into the P1 segments and that area. So I would have most likely, done DCB with Supera. But I don't know.
John, do you agree? Or you would have left it alone?
I agree.
So Rob, whenever you are ready to transmit to the next room, please go ahead. We are still watching you.
I want to see them top that in the next room. So.
Go ahead, John.
I said I'd like to see them top that now in the next room.
That's right.
Subhash, I think is an example for the audience of how not to be scared of calcium, heavily calcified vessels, because these are very crossable, just using different techniques.
Ehrin, the initial approach for this heavily calcified lesion in your hands is always an 035 guide wire and a support catheter. You go smaller.
Yeah, with this extent of calcification, I generally try using an angled support catheter and start with a straight, stiff glide wire. If that's not penetrating the cap, then I will generally switch to using, for example, an Astato 30 wire to penetrate the cap with a stiff 018 CTO wire. And then if I can get through the cap proximally, I'll then de-escalate back to a somewhat safer wire.
You are right, because you're kind of often working, high and low. You start 035, you work down to 014, you work back up to 035. That's sort of a common course.
Any benefit in these cases, assuming that the profunda origin is fine, is take the sheet down. Andrej, we are ready. We are just discussing to fill in the time, and we are ready for your transmission. Please take it away.
Yeah. Okay, yeah, thank you, thanks. Okay, so yeah, we can actually, I think, start here with the second case. Can I have the slides, maybe? Yeah, again, Mehdi, you allowed me to do what I think is interesting, and here we thought to also choose a relatively complex case, which today turned out to be even more complex than I thought. So this is a 69 male patient. Sorry, with me is Dr. Matschuk from our team, also a senior interventionist here. So this patient has severe claudication, right cough. He has rest pain, in fact, during night, a little bit difficult to understand, but is a pretty clear patient, and we have to believe this. He had quite some treatments already, starting 2003 with PTA right external iliac artery, with a total occlusion then thereafter quite early, with the iliac, actually common iliac to femoral, actually to profunda bypass during the same year, and some reocclusion. And during that, in fact, he has an SFA total occlusion, and we had a hard time to find the surgical report, which is now 14 years old, but we know one of the vascular surgeons from that center, which confirmed to us that actually during that time they did not cut off the SFA when they did such a bypass on the profunda artery. Today we found the report, and the SFA is in fact cut off, which we want to recanalize today. Well, we have done this in several cases. We have now around 25, 26 cases, and we were successful in all of them except 2. So we have techniques to reconnect a SFA if it's cut off, and hopefully we can demonstrate you here in this case some of our techniques how to do this. He had a bypass reocclusion quite recently, and still he complains of symptoms, and you can see the ABR is still relatively bad. Next slide, please.
Just a question. You say transection. Is that transection or ligation? Was it tied off or is it actually cut?
Both. They ligated it and they cut it off.
Why?
Yeah, we have actually recanalized some of the cases where they have actually used the proximal 10 centimeters of the SFA as a patch to go to the profunda artery. So we had to connect through an area where there was actually no artery left anymore. And that was also successful, in fact, in all these cases. The 2 cases where we failed were actually those where they had quite some prosthetic graft at the profunda area, and when we poked to the profunda area to the graft always jumped back because it was so soft. But we learned now, and we have actually in the past, we always had success with these kind of cases. Can take long time, and I cannot rule out that in some other cases, maybe today, we still fail, but we feel nowadays, or now, quite confident maybe to also show this technique and try it.
Andrej, while you start working, I just can't hold myself from not asking this question, that after the SFA is transected so many years ago, does it recede away and you have no idea where it is currently? So any kind of imaging before this procedure would help you. You can continue with your work, but this is something worth considering, I think, for us.
Yeah, I don't think so. So we have tried CT, and if there is no calcium, it does not really help you. Ultrasound, there is a lot of scar. The visibility of the structures, I think, is not easy. MR also not really, haven't had the feeling that it's very helpful. So therefore, we just try it, and maybe we have success.
So, Andrej, being a surgeon, really, if we do use the SFA proximally, we usually lose about 10 to 10 centimeter almost, and we clean it from all calcium, so you will not see it. But if it is not being used as a patch, Usually we ligate it. I don't understand why should anybody transect it if it is only a bypass.
The only time is in.
Not understand.
The only time is in the redo groin. Then the profunda access is very, very complicated. You may choose to transect the chronically occluded to access the profunda safely, but that is the only setting that I will think transection of the SFA which opens to anatomy exposure of the profunda.
We are eager to see your strategy and technique.
Yes. And well, that's. I wanted to mention also this. Of course, this is a sign for being quite sure that the SFA is cut off. If you do not have the report, that of course the calcium at the proximal part is missing.
What's the status of
Okay,
PQ
so
bypass
here
in
is,
Europe?
Let's go to the next slide.
What's the status of PQ bypass in Europe? I mean, because obviously that would be a device that's optimal
Yeah,
for
we
this.
have used also PQ bypass, could be an option here. The problem here in this case is you actually for a PQ bypass you need a little stump proximal to have the covered stent look into the SFA. If you don't have, if you cannot access from Antegrade, you cannot. Yeah, I mean you could puncture out of the common femoral artery, but then your covered stent would maybe protrude over the profunda origin. Maybe a little bit risky for the profunda. Also here coming from retrograde, of course, it could be risky for the profunda, but usually after surgery the profunda is very big, so we haven't seen any compromise of the profunda with our technique. With PQ bypass, not sure. Maybe a risk, but maybe not. Could be an alternative, clearly. So you can see here the angiography of the last surgical or hybrid procedure. It looks the same now. And next slide, shows you what the intention. So left going crossover, 7 French again, in case we need a Viabahn. Retrograde, clearly you cannot get in from Antegrade, so clearly first approach is from retrograde. Here the question where to access poplitea, have to turn the patient, no good idea. This complex case, so we puncture the distal SFA. Usually in these cases we actually puncture directly the occluded artery, because in an occlusion you can take everything in, 4 French, 6 French, no risk of bleeding. Here in this case I show you it may not be necessary to puncture the occluded segment. And then we try from retrograde to come close to the common femoral artery and then use a re-entry device. If this is not possible, we use other devices like transeptal puncture needles from cardiology, which of course are offline here, but have helped us here in these cases tremendously to get access back into the common femoral artery. Later on, of course, also a difficult part starts with PTA. Potentially you need some atherectomy of the first part, the ligated area, where there is so much scar to open it to facilitate balloon dilation, and then we continue with stents and drug-coated balloons maybe. Okay, let's switch to the angio. Yeah, so here once again the angiography, again looks similar. Seeing this flash occlusion, it really looks like a cut-off SFA. Of course, you cannot be sure. In any angulation, we didn't see any stump, of course. And now you see here, there is a little channel here going up from the adductor up to the middle portion of the SFA. Usually we puncture into the middle part of the SFA with an 18-gauge needle, take a stiff traumer in, we are subintimal, so we really gain access to an occluded artery, and by this we do not have any problem with bleeding, whatever kind of sheet we take in here. Distal to this good segment, and outflow is also actually quite nice, and down to the foot, the posterior artery is seen. Okay, so first part is now to really try to get access here to the SFA, and for this I go with my C-arm a little bit left oblique, a little bit like 30-degree maybe, and give a little bit of a local anesthesia here into the skin. You can see a little bit of calcium, so if it would be an occluded artery I would have actually my needle to that calcium. In this case, however, we tried a little bit differently to maybe get access here to that tiny remaining channel. Mal ganz ruhig halten das Bein, jetzt gibt es mal einen ganz kleinen Pieks am Oberschenkel, nicht erschrecken. Ne?
So you are 30 degrees LAO. We will be silently watching your instructions here.
Yeah, so the right leg is a little bit 30-degree contralateral, And so this technique is now similar to puncturing an occluded artery. You do not puncture the distal portion of the SFA, but rather more proximal or mid, where the artery is more superficial, where you can take the needle more shallow into the artery, you have better push, and therefore I give some local anesthesia here now to the mid portion of the SFA, maybe here. Jetzt gibt es einen kleinen Pieks, nicht erschrecken, ne? And then a 7 centimeter needle should actually be enough. In this case, well, usually for distal SFA punctures, we take 9 centimeter long needles. Shall we take 9? Yeah, we have 9 here, so let's try. And we take an 018 wire in. Tut das noch weh hier? Piekst das?
So, Andrej, could you walk us through this technique?
Yeah. So you see here now, in the left oblique view, the needle, what I have, should be really in alignment with the artery. So really should be on top of the artery. When I inject contrast here, you hopefully will see now the artery on top of the artery. It's not completely on top of the artery. You may change now the C-arm position a little bit like this, but better is to really take the needle out once again and reset it 2 millimeters to the left side. So what you should not do is definitely to change the course of the needle during puncturing. And then you, of course, try to approach the artery a little bit from the side, and you can miss it, of course, because you never know how deep that artery is. I give
So, Andrej, why?
Something more local here.
Andrej, why not ultrasound?
Ultrasound could also be, of course, a good option here. I find ultrasound, at least in the distal SFA, challenging. So therefore, we prefer X-ray, and especially also for an occluded artery. I found ultrasound difficult. So in this case, in occluded arteries, it's definitely actually just X-ray without injection of contrast. Okay, but you see here, your roadmap is only there for really having an idea where the needle is. Once you touch the patient with the needle, or the patient by itself moves, the roadmap doesn't have any help. The next thing, when you do not know how far you're in with the needle, is to change C-arm now to something like 30 right oblique or 40 right oblique. So first it helps you to see where the needle tip opens to, and now I changed the needle tip direction. And now, of course, you can give another puff here to see how far you're still away from that artery. And, well, we are through. Yeah, so that can, of course, in the mid portion, you do not need to go that far in, so you can pull it out. We may have punctured through it. So clearly, these other angulations are extremely helpful. And I give another little injection to pull it back. Maybe we went through the artery. I think there is some blood coming out. Could be vein. Could be the artery. Let's check. Let's try. So I have here a V18 with a little angle here on the top. And I tried to get it in here, but it could, as I said, also be within the vein. No, what do you think? No, vein or outside? Yeah, it doesn't matter. Let's try once again. This is also outside?
Outside.
Okay. Let's try once again.
So, Andrej, this is a great demonstration of your technique. We're watching you very carefully. So, you're going to restart again?
Yes. So, I went again back to left oblique now, of course.
Is your needle very vertical or shallow?
It is, as you can see, relatively shallow. Especially for puncturing totally occluded arteries, you need a shallow approach because you need that to push into the artery. You see here, this is the angle between artery and needle. And well, if you go more distal, of course, then the way from the skin to the artery is relatively long, and you may need to go a little bit more vertical. But here in the more mid portion, your artery is more superficial, so you can go more shallow. Yeah. I don't know exactly. Here, of course, we can try now a little bit. Definitely, if it would be a renal insufficiency patient, I would use now ultrasound. But here you see how, what do you think? Is it inside?
It feels like.
Strange. Seems like the blood which just comes out is, however, a little deep, dark, sorry. Let's see once again, yeah. So a small segment, maybe a little bit more challenging here to puncture.
While Andrej is doing this, I have a good question for the panel. There is also a distal segment, and Andrej gave some great explanation why he did not access the distal segment. Is there anyone on the panel who feels differently and actually might go a little bit lower?
You know, sometimes if we know we're going to need retrograde access, we'll, on the bed, flip him over with ultrasound, get popliteal access, put a longer sheet, and then put him back on the table supine. And then usually we can have work from both access sites at that point.
Ehrin, I've seen you do the case like this before. Can you tell me what you did?
Yeah, I do often access a little more distally just to have enough wire purchase as well during the access. I think the key with that, as Andrej mentioned, is that you have to often puncture a little deeper, and you have to really make sure that this angle is not too abrupt. One technique that he's described and others I think are very helpful here is to take a long micropuncture needle and put it inside of a Cook needle. That provides enough support that then you can get that deep into the artery without perhaps bending the needle.
So Subhash, I mean,
John,
you see this all the time. So I mean, if I was convinced I'd get across, I probably would have punctured a good segment of popliteal, recanalized, and then gotten balloon hemostasis. If I was unsure I'd cross, I probably would have gone posterior tibial. I mean, that's a good posterior tibial, low profile just across, and that way you don't have to worry about hemostasis later. This is fascinating again, watching him go into the occluded segment preferentially. He's still going to have to treat below his puncture site, so he's going to have to kind of turn everything over, everything around. So.
Beautiful demonstration. Where do you think you are right now?
I don't know. A little bit strange here.
Yes, it does.
Could be subintimal, could be outside.
Mehdi, does the loop tell you something here, information?
The loop is a little bit too big.
The loop goes up so easily that I'm afraid I'm not in the artery.
Yeah,
or vein, perhaps.
This is the vein. It's a big loop. And go ahead, Munier, please.
So really, I still think ultrasound much better to go even distally, and you have better purchase here. I mean, you always will get it by ultrasound. No way you cannot get it.
Yeah, ultrasound is indeed, I think, a good option.
Andrej, some comments from the panel here is to try to convince you to go a little lower.
Yeah, actually not really. I could go a little lower. 7 centimeters.
It's also refreshing to see.
See a little bit. Yeah, sorry. It doesn't really show you the ease of this technique here now.
It's also refreshing because we've been watching Andrej for years, and he almost always gets it the first time. So thank you for missing it a couple of times. You make us feel a little bit better.
Andrej, you make us feel so much better now that if Andrej can miss 2 times, then I can miss 5, huh?
So, Andrej,
So I need to press here now a little bit.
so Andrej, what about surgery here? Why not to open the groin, find the vessel, and connect it if it is disconnected?
Yeah, and that means the third time surgery.
It's under local even. You don't have to give general this area.
But I think, well, we indeed discussed with our surgeons, and due to the fact that there's so much scar around, we agreed that we give it here first an attempt endo before we try surgery or do surgery. That was the reason. The reason is this.
Why would you not try?
Already 2 times.
Why would you not try endo first, Munier? Given that the groin has been, transected twice, and why not give it a try? Because I don't think he's taking the surgical option out by doing this so far.
So really, you don't have to go the same scar. You can go. You will always find the graft easy. Go a little bit distal, find the SFA, and connect them with the graft. And all do endo. Then the rest of the artery do endovascular, so it will be a hybrid procedure.
Right, but what I'm trying to understand, because this comes up all the time, is that why not try endo first? I mean, if he's not going to take your surgical option away.
No, because of the nature of the procedure. He says it is disconnected, which I doubt, by the way, so far, that is disconnected the way the bypass is.
Oh, because of the transection, that's why you say
Yeah,
that.
this is because of the transection, that's all. Otherwise, I will try endovascular.
Right, I see what you say.
John, when Andrej started this case presentation, he said, I didn't try popliteal because the patient was not prone. So I want to ask you, in this particular case, if you had to do a popliteal access, would you do the frog leg approach? There is very little popliteal left, or you would actually, in this case, in rare situations, actually put the patient prone and plan the procedure that way?
No, I never put the patient prone anymore. So it's either frog leg or it's an anterior P3 puncture between the tibia and the fibula.
Any Christian and Ehrin, Munier, any comments?
I really go supine, no more prone, and I go the highest point I see in the anterior tibial or posterior tibial artery, the highest point by ultrasound.
Any other comments here?
Andrej, why not posterior tibial? I know it's a single vessel runoff, but you could have a 4 French slender sheath, a 4 French coaxial 2.6 or 2.3, and try to cross this retrograde, no bleeding risk, plenty of working room to try to recanalize. I mean, you guys are obviously experts at that. Why not now?
Posterior. You mean the posterior tibial?
Uh-huh. Yes.
I think looks like he's in.
I mean, I expect that I need a re-entry device from retrograde. And therefore, that will be 6 French. And therefore, clearly, I will not take the posterior tibial artery. For the proper needle, I only need 4 French, but very helpful would be to have a very direct access to the occlusion, to the culprit lesion, and from the posterior artery up, that way is too long.
Although you guys have showed us in the past the technique where you come retrograde and you can either create a balloon target or a snare that you can now enter into from the contralateral femoral approach. So you don't need, you can keep it a low profile distal sheath, get a balloon all the way to the top.
I think you're in, that's
fantastic. Into that balloon.
Yeah. Sorry, I don't know why it took so long.
It's still a very big loop, though.
It's a collateral.
It's a branch?
Collateral.
Okay, branch.
Minute. Let's take now the quick cross in and check.
So, Andrej, what did you, in your opinion, had to adjust here? The depth of the needle was the main factor here, or so? Can you enlighten us a little bit?
I think the artery where I punctured that small channel easily dissected.
I see.
And therefore the wire, I'm still not sure whether I was in the vein or in a dissection, but probably in the vein. And then it was hard to really feel where the wire actually has its proper way up. But now you can see there is some reddish blood here coming out of the catheter, and I will inject now. We are a little relatively deep now in the SFA but still I'm in the diseased segment. So at the end, once we will be hopefully successful, I will balloon over that access area, and even if I have a 6 French sheath in, that should then not be a problem of bleeding. Okay, so now I take here the V18 little higher up. So I think we can directly now take here a 4 French sheath in. Look at this, I mean how easy that goes here into the... Probably I have been in the artery also before that already. That's strange, isn't it?
Yes. Munier, does this appearance of the tip tell you something as a surgeon?
Most probably, actually, it's not atherosclerotic occluded by thrombus, all the thrombus. It went very easy, actually. It's in the vein.
Okay.
That's the vein.
Okay, so I should have tried during the first attempt already with a catheter.
Yeah.
Okay, let's now take a 4 French catheter in and try to get as close as we can here. 4 French Turboschulter.
Yeah, exactly.
As close from retrograde to the common femoral artery as we can. Okay. Yeah. So this is a Terumo 4 French which tracks over a 2.5 inch wire. So introduction profile very, very small, slim.
So it looks very large artery. Are you sure this is not a graft? He did not have a bypass before?
No, according to the report, and also no scar here distal, no graft. Yeah, looks big. As you said, doesn't look really atherosclerotic. No. Old occlusion maybe. Judkins here, French?
So Andrej,
I think definitely there is a stop.
Andrej, can you talk us through what is the next approach to get in? What kind of catheters are you selecting here?
Yeah, so the next step is to get as close as I can to the profunda, or to the common femoral artery. If I can come very close, still I need to try to somehow get the wire a little bit parallel to the common femoral artery to be able to use a re-entry device. I think a Pioneer catheter is here very helpful. Terumo, steif gerade. And if I cannot come close here to the profunda artery, then I need the Brockenbrough needle, the transeptal needle. You can see I have problems here to get the catheter high up. So now I have to predilate a little bit. Predilate maybe a little bit from retrograde. You see here, this wire will not help. This may be the stop. What do you think? Where the artery
I think so.
is cut.
Anyone in the panel? Mehdi, you have a specialized approach in these situations?
And, I don't think I've ever done a case with the transection, but actually I know I haven't done a case like this before, so I think that he's going to end up using the needle, the Brockenbrough needle, because I don't think the devices are going to be able to go through.
Ehrin, you did this case. Did you not advance the wire loop in this situation?
I've done 2 cases of one sutured and one where it was cut off like this, and in one case I had to use the back end of a straight stiff glide wire to puncture, to actually even get close enough to the common femoral, and then was able to advance a Pioneer catheter. The other case, there was a suture line where I was unable to dilate any balloons. 40 atmospheres, there was a waste, so I actually brought a cutting balloon up from below and snipped, presumably, the suture line, and that made it possible to complete the case.
Christian, I want to invite you in. Any advice you have here? He's not, looks like too close to use a re-entry device here. Would you agree?
Not there yet.
If it is a question for me, yes, absolutely. So here, there is the stop. No way to be able to use this even stiff, straight Terumo to get it higher up. You can, of course, use now a little bit the back end of the Terumo to break maybe upwards. It may give you the wrong direction. The Brockenbrough needle is in this regard better, but for a start, of course, we will start this here. We take a clamp here around the wire and the catheter, leave the wire a little bit outside and try to poke a little bit in. But you see here, it's not really giving me a good direction, and in fact, also not giving me the strength to break through here. Yeah, so this is now comes again that point into play, which is important. If you puncture too low, if you have a relatively steep access into the SFA, that diminishes your push you have up to the common femoral artery. So therefore, my first attempt was to puncture a little bit higher. Unfortunately, I didn't insist. But nevertheless, I think we're going to try here now to take...
And Andrej, you have a short sheath in now. Would you try to bring a longer sheath all the way up to that occlusion so you get extra push?
Exactly. We are going to use now a longer sheath if we have. Also mal eine 5 French 55 cm sagen. It would be a 5 French 55 to have better access. Kurzer Supercore.
So, Andrej, we just want to let you know that you have 20 minutes just to keep you on track. So.
Yeah, I know. For this step, of course, we need a little bit of time. And we have to approach that concept and step by step with many different angulations and movements of the C-arm to have the appropriate direction upwards. So let's see whether we can do this in that time. What we also will do, we will engage a Judkins 6 French guiding catheter from Antegrade down to the common artery to position the tip of the catheter right there where we actually want to hit to. Alles okay?
Andrej, what sheath are you using here now? What centimeter? 25?
Yeah. 55. Hopefully this is not too long.
55.
For the Brockenbrough needle. Kann man die Brockenbrough needle haben? So this is the Brockenbrough needle. It's long enough actually to go through. Yeah, it comes with a sheath. It comes with an outer metallic sheath and an inner needle. And the inner needle is straight and actually fits through a 4 French sheath. And the nice thing with this one is, of course, you have very good push. It may not be sharp enough, so sometimes we actually take 014 wires back end to drill through. But the nice thing is that you can give it a bend, the bend you want to have, and that really helps you much better than the straight back end of a Terumo.
Makes sense.
Okay, let's first take the Judkins 6 French guiding catheter down. Noch einen kurzen Supercore. Yeah, I position that sheath from retrograde as far as I can. Halten. Well, for this, indeed, you need quite some patience.
And we will let you focus entirely on the procedure and not distract you, so we are watching very intently.
Okay. So with this catheter now, first we want to position it and find the place where we actually want to aim to. So let's change C-arm position again.
So what angulation are you going to do this right now?
Now, usually it's some kind of changing from relatively right oblique 45 degree to left oblique 45 degree. So it's really something of moving between a 90 degree angle. That is too far in, sorry. So catheter should be somewhere here. Maybe this could be a good place to re-enter here.
Do you actually feel it, the proximal part at all, or the ostial?
Yeah, that's also a good point. You can try to feel it. I expect in this case that I cannot feel it. Just a moment. Nochmal vor 18 oder was? There it looks a little bit like a little stump, I must say. That could be a good maybe target to go to.
Munier, you are the surgeon. Does it look like?
No, actually, I will go a little bit higher, Andrej, because it looks the end of the graft here. If you take more angle, a different angle, it might show it better.
Yeah. But can you see, according to the femoral head, it's relatively deep already, isn't it?
Yeah, but they are overlapped, so you need to separate them as much as possible.
Andrej, in such situations, have you ever used an ultrasound catheter probe on the skin to tell you where the proximal superficial femoral artery could be?
Yeah. Yes, I found it very cumbersome, and actually rather use this catheter target technique.
We
need to go a little bit higher.
Yes.
Although I think if the artery is cut off, why not try to get there? Not in this angulation, but at least in this angulation here.
Andrej,
if we get access here to the confemoral, we are far away from the profunda.
Andrej, do you think it's better to be a little bit higher so when you do re-enter and you put your stents, you don't compromise the profunda? Is there any advantage of being a little bit higher because it's wider, it's a little bit wider in that area?
Yeah, for sure. Yeah, that's a good idea. At the other hand, I mean, you see the profunda is very big now. Once we get back here with the wire, hopefully, we will use some atherectomy to clean this out. And by this, we actually haven't seen a compromise of the profunda artery in these kind of cases. But clearly, that is maybe a good idea. Nevertheless, I think we have defined some kind of target here now,
So,
different angulations where we want to get to. And now we take the needle in.
Andrej,
and for this, we need also a new V18.
So, Andrej, is it an end-to-end or end-to-side anastomosis? Did they mention that?
Well, they mentioned that they used the patch and took the patch from the common femoral to the profunda.
Correct. So that's a point I wanted to make surgically, which is that bulbous proximal profunda may very well represent the patch into the origin of the profunda, and the actual proper common femoral is above, which it's just it's semantics because you're going to re-entry there anyway. But my question was, and we are big fans of the profunda patency, techniques to protect while you're re-entering, wiring it, etc.
No. Yeah, as I said, I mean, there's also this case. I mean, the profunda looks very big after surgery. So therefore, we didn't have so far, in all of our cases, any problem with profunda occlusion or,
So are you straight away advancing the needle?
Once we have treated this. I was straightly advancing the needle now, and now, of course, I have to start to do this in different angulations, to change the direction of the needle until I really reach an area where I want to go to. In fact, in this case, I find it not so easy to position my catheter from Antegrade properly. Maybe here.
Yeah, actually,
so
here it looks good. Yeah,
That
looks good. Yeah.
I like this here. Das weh? This is the right direction in this angulation, but probably in this one completely wrong. Yeah, and then of course you have to modify several times. You may need to take the needle out once again to give it another angle.
How about a snare on top? You give a bigger angle.
Sorry?
A snare on top to give you a bigger circle to target.
Yeah, you can also do this, of course. I think there are many ways to do this. Now you can see here that now the needle is not directing to the right position. I may pull it back a little bit and give it another angle. So I have, however, keep in mind the direction I twist the needle. So I twist the needle clockwise to my side, and this is very important for the next steps. So here you can see if I feel scar. Again, I came a little higher now. And now I want to change angle again to see whether I'm also in the other angulation quite close. So this is really not a step where I can rush. And this angulation also not so bad, but as you have seen from the other angulation, I think the angle of the needle is not enough to now give me the appropriate push to get the needle back in. So I twist the needle, as you can see here, a little bit back here and give it a little higher, maybe here. And that angulation, and leave it like this here and change angulation again. Maybe draw, doesn't look too bad.
That looks pretty promising actually.
Coming close. Now I wish I had a little bit more angle in the needle. So I may do this by leaving the wire here now. So these are that stuff. Problem sometimes with this wire is that you may shave off here the material. I think it's not a problem because you're outside of the artery. It cannot embolize anywhere.
Agreed. Andrej, we don't want to rush you, and please take your time, but just to let you know that we have 7 minutes.
That's good. I believe this is maybe too little time to show you here everything. Hopefully the success. So I gave it a little bit, I didn't take the needle off the wire, but just gave it more angle here on that wire. Und Sie halten den Draht wieder. This is somewhere. Oh, here it is. Now let's see whether I can take the wire back. Okay, once again, I try to give it a better angle to the common femoral artery. So this, for example, is a good angle to poke a little harder. However, of course, not before I have again changed CR position and checked. Now CR doesn't move. Please. So Sorry. Come on. Little injection there. Okay, I think angle like this is not too bad. But here now it's in alignment to the common femoral. And now, of course, I want to see how it approaches the common femoral from the lateral side. It's my roadmap now. That's actually the point where I wanted to hit to.
Right.
But it jumps away here. Probably I need more angle, or I take now a 014 wire. Über die Schleuse hier halten. Die müssen wir von meiner Seite aus halten. 14er Draht, PT2 und eine Klemme. Einfach diese. Ja, schön. Yeah, now you need 4 hands. Spinning hello. Yeah. And now I try to push once again that needle high up. But you can see it now. It's jumping away here from that proximal end. Here it's a little, yeah. So this is an access a little higher in. If it can access here. Now I can change once again the C-arm position to see whether I'm correct. Oops. This is not correct, so it will go back a little bit and change it to this here. Again, sorry, need to change C-arm position. So this is quite frequent that I need to do this. And now really I need that time to do this. And in fact, I think, as I said, that needle is not really very stiff and pokey and sharp at the end. I take an 014 wire and take the back end and give a little angle into the back end with the clamp and then drill the wire through.
Which wire are you picking here?
Yeah, it's any 014 wire because, I mean, the back ends are usually all the same. And, oops, I try to, this clamp doesn't work, haben wir mal eine andere? Shall I now? To make a little angle in it, something like this.
Sure.
Something pokey which will drill.
Andrej, when you leave the needle, does it stay in position? It looks like it does. Does it not sometimes spin away?
It does sometimes spin away. So before I actually try to drill here, I would probably check once again the different angulations. But it's let's say it's semi-stable.
This looks very promising. You look like you are very close, at least in this view.
Yeah, and here clearly you need your time because now you really want to take that wire and drill and check.
Andrej, just keep doing your work. We will just tell you that we are going to wait out the next 2 minutes and you focus on the case and we will close off as soon as the transmission ends. But we want to take the advantage of the very last second, so you keep going.
And thank you, Andrej, for all your...
Thank you.
Thank you.
We are still on, and we want to congratulate you for these fantastic cases, your colleagues and your entire team, and demonstrating such outstanding technique and strategies. It is a pleasure to always listen to you and see you work. We have another minute and more, and a lot can happen, so we'll keep watching you. I also want to thank the esteemed panel for this very engaging discussion, lots of thoughts shared, and we are a multidisciplinary panel here. So, and I think it lives up to the theme of the word cardiovascular innovations. And of course, thank you all for being here. So let's watch this all the way through.
Okay, also this angulation, that's actually a correct direction. And now we have to keep on trying this. And this backhand technique with an 014 has been really quite successful in the last cases. We may need to take the needle once again out to give it a better direction here.
So Andrej, if you can send, you have my number and Mehdi's, if you can connect and share some images or an angio with me through email, I will be happy to show it to the audience.
Okay, perfect. Yes, we'll do so.
Thank you very much, and we are about to end the transmission. Thank you very, very much for being here.
Great. Thank you very much.
Thank you.
Thank you again. Any final comments from the panel, and then we will resume our break.
What can you say?
So really, from surgical point of view, I would have done it. There's no question. Surgery much easier, much easier.
Well, let's wait out a few more seconds, as long as we can. Rob, you can take it away when it finishes, okay?
It's working.
30 seconds is a long time. That's great.
30 seconds.
I think what was interesting through all these cases is that there are multiple things to learn from Andrej, not just the crossing. Every step and every technique he uses are so clearly deliberated. Mehdi, please.
Now, I was just going to say, I think the thing that you learn the most about him is that he's so careful and calm, and also takes his time. You know, I mean, the first case really highlighted, you know, that the amount of time he took to just pre-dilate and post-dilate. I mean, we just don't do it. I mean, we've seen a lot of operators, myself included. We want to just do it quickly. So, you know, it was really a pleasure always watching him, I think.
Thank you. Let's resume our break here, and thank you all.
Subhash, one quick question.
Yes, yeah.
Any of the panelists, what is he going to do next? I mean, what's going to be the end result?
I think he is going to externalize and then balloon and stent, but he also has a distal occluded segment. So I think if he can come down that main SFA, he will have a much easier chance to connect the short segment. I think that's what I think would be the strategy here. Any other opinions here?
So there's no vessel there. For 7-10 centimeters, there's no vessel. There's subcutaneous tissue. Muscular tissue there. So how is he going to connect channel? It's been transected.
Yeah, at the very top, it's got to be a viabon. And
you're going to cover stent.
Any option down.
Segment.
So the viabon is going to extend into the, not across the profunda, obviously.
No,
but it'll
mouth up into that patch at the common femoral. So. Yeah.
Very well. We'll leave these discussions into the future other sessions we are going to have today. So please take your break and join us for the peripheral session in the Colorado Ballroom at 10 o'clock, 10:30. Thank you.